Ladies and gentlemen, welcome to the Surviving Sepsis Early Management Save Lives conference call. Your host for today, Lauren Smith. You may now begin.
Hello, everyone. This is Lauren Smith with MPRO, Michigan's quality improvement organization that is part of the Lake Superior Quality Innovation Network, or Lake Superior QUIN. Lake Superior QUIN represents Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization Program. This webinar is presented in a collaborative effort between the Lake Superior QUIN and Great Plains QUIN, which includes the states of North Dakota, South Dakota, Nebraska, and Kansas. One contact hour for nurses will be provided for today's webinar by the North Dakota Board of Nursing. When you close out of this webinar, you will automatically be redirected to the evaluation. In case you have multiple attendees, the evaluation will be emailed to the individual from your facility who logs into the webinar. This email can be forwarded to the other staff members in attendance who wish to receive the continuing education certificate. The certificates will be sent 3 to 5 business days after completion of the evaluation. Since sepsis is a top readmission diagnosis for patients in all of our states, we are focusing a webinar series on sepsis. This is webinar part 1 of the series. I would like to welcome you to this educational session entitled Surviving Sepsis Early Management Saves Lives. Before I introduce our speaker, I'll mention that all lines are muted during this webinar. However, after the presentation, we will have a time for questions and answers, so please make a note of any questions that may come up as you listen, or you may use the chat feature, which is on the right side of your screen. Now, I would like to introduce our speaker, Pat Hoza. Pat Hoza is the Population Health Clinical Integration Leader for St. Joseph Mercy Health System in southeastern Michigan. Pat has been involved in many quality and patient safety programs such as hospital and system-wide sepsis management program and a statewide Keystone ICU patient safety initiative. She has been faculty for multiple state and national clinical collaboratives, including the Surviving Sepsis Campaign Phase 4 Collaborative and the National Project on Comprehensive Unit Safety Program for mechanically ventilated patients. Through Pat's leadership, St. Joseph Mercy Hospital was awarded the Department of Health and Human Services and Critical Care Society's Outstanding Leadership in eliminating CLABSI and ventilator-associated pneumonia in 2011. She was inducted as a fellow into the American Academy of Nursing in 2013. In 2017, Pat was awarded the Michigan Hospital Association Quality and Patient Safety Leadership Award. Pat, I will now turn it over to you.
Well, thank you so much, and I'm excited to be here. As Lauren said, this is part of a series, so this first part of this series is going to give a broad overview on what sepsis is and how we currently manage it. And the next part of this series is going to be early recognition and management of sepsis in the post-acute setting, including a description of a toolkit for the post-acute setting. So what we're going to talk about over this next hour is understanding the incidence of sepsis, discuss the difference between sepsis, severe sepsis, and septic shock, define an early recognition process for severe sepsis, and what are the evidence-based interventions for severe sepsis. I'm also going to share some national data on how people are performing in implementing the Surviving Sepsis Campaign bundle. Sepsis affects 1 million Americans a year. They're the leading cause of death in the United States. Sepsis occurs in about 10% of the patients admitted to a hospital, but it contributes to over half of the hospital mortality. This is what has driven me for a number of years to work on improving early recognition and care of our patients with sepsis. Is 700 people die each day in the United States from sepsis, 1 death every 2 minutes. This is an epidemic. The CDC is a great resource. They did a study that was published in August of 2016, and here they identified that 80% of the sepsis begins outside the hospital. Our focus in the past 10 years have been in the hospital setting, in the ER, and on the floors, in the ICUs, in early recognition and management. But we know that most sepsis begins outside the hospital, and so we have to go beyond just the hospital setting. 7 out of 10 patients with sepsis had recently used healthcare facilities or have a chronic diagnosis and that receive frequent care. Most common infections, lungs, urinary tract, gut, and then skin. They have a lot of resources for patients and families on sepsis that your organization can use, and you can see this nomogram up at the top, Know the Signs and Symptoms of Sepsis, is just one of those. Our elderly population are at high risk for sepsis and for sepsis mortality. This is just a report, and it was back in 2008. As you can see, in male or female in increasing age, you have an increased reason for hospitalization to be sepsis. And so 85 or older, you have a very high likelihood of having sepsis and needing to be admitted to the hospital. So, again, this points out our most elderly patients, those over the age of 85, and we have a lot more of those around, get admitted for pneumonia, urinary tract infection, and septicemia. We know that 1 out of 2 to 3 deaths in hospital are sepsis, and the majority of those deaths come from sepsis that's present on admission. In the Kaiser Permanente Health System in 2012, what they identified was that patients that met criteria for the surviving sepsis bundles, the early goal-directed therapy, comprised about 33% of their sepsis deaths. But patients that presented and initially their blood pressure was normal and their lactate was normal, that these patients accounted for the majority of the deaths. So it's early recognition in the ER, but it's also recognition throughout the hospital stay, because they might not come in presenting with those signs and symptoms, but progress and develop. We also know that sepsis is a leading cause of readmission, and this is just an example. It results in increase in 7-day, 14-day, 30-day, and 90-day readmission. And nationally, sepsis is now the leading cause for all-cause readmission, and so it's something that's impacting all of us. In the state of Michigan, it holds true as well. Septicemia or severe sepsis is the #1 cause for readmission, and a readmission rate sits about, a 30-day readmission rate sits almost at 22%. We also know, and it's not in the scope of this presentation, but sepsis can cause both functional and cognitive deficits, and as a result of those, patients are more likely to transfer to a short-term care facility or to a long-term care institution. And there's a syndrome called post-sepsis syndrome that is very real, and people need to be aware, caregivers and families need to be aware of it, and there are interventions that we can do in the hospital to prevent a significant post-sepsis syndrome. We're not going to talk about all of the interventions specifically today, but one of the interventions to minimize cognitive and functional deficits for patients with sepsis is to early recognize sepsis and treat it aggressively. As I shared in the previous slide, sepsis has a significant impact on the elderly. Age itself is an independent risk factor for death. They're more likely to need an ICU. They have the highest mortality in the 85-plus group, and often a prolonged hospitalization, and they are at significant risk for the post-sepsis syndrome. We need to improve our general awareness of sepsis. As I shared with you, 80% of sepsis begins outside the hospital. So a group called Sepsis Alliance, and they have a great website, sepsis.org, lots of tools, patient stories, and facts. They do an annual survey to get a gauge on how aware the general public is of sepsis. It's killing someone every 2 minutes, yet only 58% of the public had ever heard the word sepsis. Now that's improved over 2016, only 55%. So 7 million more adults are aware of sepsis in 2017 than 16. Those under 45 are significantly more likely to have heard the term. An alarming 39% of Americans believe that sepsis is contagious. A quarter of us only believe that it happens in the hospital. 3/4 of Americans say they can identify symptoms of someone having a stroke, where that less than 1% can identify sepsis symptoms. Nearly 58 million adults believe if you are healthy, an infection isn't anything to worry about. We know any infection can lead to sepsis. So sepsis is a time-sensitive disease, and we have taken that approach to managing sepsis. We need to identify early and manage it aggressively, similar to the strategies we've used with acute MI, stroke, and trauma, that the sooner we identify it and begin to treat it, the better the outcomes for our patients. And you can see here with aggressive support, and for acute MI and stroke, especially, the public is made aware of those signs and symptoms so they get treatment early, and that's where we need to go also with sepsis. So what is sepsis? Sepsis sits on a continuum. It starts off with an infection, and then the body can have a systemic response to that infection. That systemic response is identified by having 2 out of 4 SIRS criteria. That's a temperature greater than 38 or less than 36, heart rate greater than 90, respiratory rate greater than 20, or a white count greater than 12,000 or less than 4,000, or I have a left shift and I have greater than 10% immature neutrophils. So if I have 2 or more SIRS plus infection, now I have sepsis. If that sepsis leads to a new organ dysfunction, then I have severe sepsis. What organs will dysfunction? All of our organ systems have the potential dysfunction from sepsis from that systemic response, and we'll talk a little bit about the pathophysiology in a minute. Neurologically, you're looking for an altered level of consciousness. Respiratory, you're looking for increased O2 requirements, a drop in O2 saturation. Metabolically, you're looking, and here not just a lactate greater than 4, this should say a lactate greater than 2, would denote severe sepsis. Cardiovascularly, a drop in blood pressure, a systolic less than 90 or 40 millimeter of mercury drop from the baseline. Renal-wise, we're looking for a drop in urine output of less than 0.5 milliliters per kilogram per hour that persists at least over 2 hours, or a bump in creatinine of 0.5 or more. Hematologically, we can see that these patients have some coagulation issues, and so they can drop their platelets. And if you see a 50% decline over 3 days, then that is a sign of hematologic organ dysfunction. So the definitions for sepsis, these are called the Step 2 definitions. The original definitions began in 1992, were updated in 2003, and that's what these are. And then I'm going to share with you additional definitions, new definitions, but in the U.S., we have not changed to adopting the Step 3 definitions, so all of the information that I'm sharing with you today is based on the Step 2 definition. So we have infection, we have sepsis. Sepsis is infection plus 2 or more SIRS. Severe sepsis is infection plus 2 or more SIRS plus new organ dysfunction. And septic shock is severe sepsis with a lactic acid greater than or equal to 4, or continued hypotension after an initial fluid bolus of 30 milliliters per kilogram. We've known since the early 1900s that assessed on a few occasions the patients appear to die from the body's response to the infection rather than from the infection. Now, we need to treat that infection, but it's this body's over-response that causes the organ dysfunction and the eventual demise. So the pathophysiology in sepsis is there's an unbalance in the homeostasis. We have too much coagulation going on, too much inflammation, and not enough fibrinolysis. And so the target for the over-response is the endothelial membrane. And so this is a schematic of the endothelial membrane. The neutrophils and the monocytes are released when you get bugs, and the bugs are here on the left-hand side. The neutrophils cause the body to release cytokines, and these cytokines are responsible for some of the signs and symptoms we see. They cause vasodilatation, they cause increased capillary permeability, so the blood, the liquid intravascularly seeps out extravascularly. Also, substances, cytokines are released that stimulate both from the monocytes. Tissue factor is released and causes the ignition of the coagulation cascade. So even though I'm not bleeding, I begin to clot. And so we make a number of microemboli. At the same time, you can see on the right-hand side of the screen, normally if we make a clot, we start breaking that clot down through fibrinolysis. But fibrinolysis is suppressed in sepsis. So this pathophysiology is resulting in a lot of inflammation, too much coagulation, and impaired fibrinolysis. And as a result of that, you see impaired perfusion. This is a picture of the microcirculation under the tongue. And so this is normal circulation. On the right-hand side are the venules. On the left-hand side are the arterioles, and you can see capillary loops. Oxygen is getting well to the tissues and cells. Here is a patient that's in septic shock, and you can see we are not perfusing very well. We've lost those capillary loops, and if you look really closely, you can see microemboli. So what's happening in sepsis is my circulation is impaired because of the pathophysiology going on. I'm getting less oxygen to the tissues. As a result of that, I move from aerobic metabolism to anaerobic metabolism. I don't create enough energy for the cells, and the cells begin to die, and enough cells die, the tissue begins to die, and then we start seeing organ dysfunction. So it's all about not getting enough perfusion and oxygen to the tissue. So how do we care for patients with sepsis? What are the key components? First of all, you should have a great infection prevention program as part of your sepsis program. We'll talk a little bit about that. Then early identification, early and aggressive management using the 3- and 6-hour bundles that are recommended from the evidence. And we also want to avoid iatrogenic harm. And we're not going to talk about that today, but that's the post-sepsis syndrome and how to minimize its impact, which will also help you avoid sepsis readmission. All of these components of sepsis care need to be provided across the continuum. So infection prevention includes implementing evidence-based strategies to prevent hospital-acquired infections, Class C, CAUTI, ventilator-associated pneumonia, non-vent pneumonia, C. difficile, surgical site infections. You should be measuring your rate and your standardized infection ratio for these infections. You should audit your prevention strategies. Each of these infections has evidence-based prevention strategies. You should put those in place, audit if they're being done, learn from each infection to see why this infection happened. And a multidisciplinary team needs to be overseeing your infection prevention strategies. Again, I'll reiterate this needs to be done across the continuum in skilled nursing facilities, in home care, in the medical home, which are the PCP offices, and for patients in their home. The Surviving Sepsis campaign and the Surviving Sepsis Committee has put forth multiple guidelines. The initial guidelines were put forth in 2004 after some significant research was published. They got together multiple organizations, professional organizations, as well as experts, and put together expected care for this population. So guidelines came out in 2004. They were updated in 2008 as well as in 2012, and then the most recent guidelines are from 2016. In those guidelines, they include this best practice statement that severe sepsis and septic shock are medical emergencies, and we recommend that treatment and resuscitation begin immediately. And so it's really calling out that just like an acute MI, just like stroke, these are medical emergencies and should be treated that way. To save lives with sepsis, we need to early identify them, provide early antibiotics, and early fluid resuscitation. Early identification, the Surviving Sepsis Campaign guidelines recommend screening to identify patients. This results in earlier treatment, improved mortality. Routine screening should occur upon admission, every shift, and with a change in condition. In hospitals, we know that they also have electronic medical records that are providing them alerts, EMR alerts, alerting you if someone is meeting service criteria or organ dysfunction. It is not enough in your early identification program. You should also be doing routine screening. And then this early identification goes beyond the hospital. And we'll talk a little bit about that now, but in the next webinar, we'll take a deeper dive into what it will look like outside the hospital. So this is an example of a screening tool that we use at our hospital. We just put this screening tool into our EMR. So we have an EMR alert, plus we also have routine screening that will occur upon admission and every shift, and then PRN with change in condition. And you can see if the screening process looks for the presence of 2 or more SIRS. Does this patient have a known or suspected infection? And then do they have organ dysfunction? If they have 2 or more SIRS infection and new organ dysfunction, then they screen positive for severe sepsis. And in our facility, we have some standardized protocol orders that the nursing staff can do, and they're outlined here. What's at the bottom of the screen is based on if they screen positive for severe sepsis, and based on their blood pressure and what their lactate was, we identify where they should go in our organization. If they're in the ER, should they go to a general floor, an intermediate floor, or the ICU? So efforts to just recognize sepsis alone is not enough. The critical aspect of reducing mortality is by pushing practitioners to identify sepsis early in the process. Knowing that every infection can result in sepsis, we need to be alert and watching for that movement. It may well be that early recognition accounts for much of the signal in mortality reduction, and also partially explains the increasing incidence, right? So we're recognizing it more. But without early recognition processes, the clock begins ticking, and we need to set those processes in place so that we can early recognize and treat. So going beyond hospital walls, as I will say over and over again, it is all about the early. So in our organization, we've partnered with EMS, and this is happening around the country as well, and they screen for sepsis. They will begin fluids for hypotension. Some of our EMS will draw lactic acids, and so scheduling in this patient then to the ER, they already have some things identified and begun. We need to partner with our PCPs in the medical and surgical homes to educate them on sepsis. This is a study out of Colorado where they saw a 24-minute improvement in getting that first antibiotic hung with having the EMS identify sepsis early. This is an example of our EMS Identification and Management. We put it in place in 2012. We updated it in 2016. And again, it has them screen for sepsis and then what to do if they identify it. This will be, we've partnered with skilled nursing facilities and had them put in a early recognition sepsis screening process. This is the example on the right-hand side of the screen, and we've created a toolkit, and this will be the topic and the focus of the next webinar in this series. Home care, we also need to impact home care. We'll take a deeper dive into this in the next series as well. Next part of the series, New York State has partnered with their IPRO and has put in routine screening for all home care visits. And so that is where we need to focus as well. So in managing our sepsis patients, once we identify sepsis, we follow the recommendation of the Surviving Sepsis Campaign guidelines. The most recent ones were published in 2016. Is the Consensus Committee of 55 international experts representing 25 international organizations. They use the GRADE system to determine the quality of the evidence, and then they use best practice statements for ungraded. So there's not evidence, and sometimes you're not going to find evidence. For example, give antibiotics or not to give antibiotics. No one's ever going to do that study. So that's an ungraded, but it's a strong recommendation to give antibiotics quickly. So the guidelines have been put into bundles of care, and they're time-sensitive bundles. So they're called the Step 1 because, as I presented earlier in the presentation, the majority of patients that are hospitalized for sepsis are over the age of 65, and the major insurer for those patients is Medicare. So CMS has mandated that we follow the sepsis guidelines and that we measure how effectively we're doing that. And I'm going to show you some of the national data that was presented on a recent webinar on how well we're doing nationally. So we have a 3-hour bundle, and then we have a 6-hour bundle that has 2 parts. The 3-hour bundle needs to be completed within 3 hours of the time of presentation, but you'll see as I present some studies that you don't wait 3 hours to do it. You just begin it as soon as you recognize it and ensure that you're completed in 3 hours. And we'll talk a little bit more. I see in the chat antibiotic stewardship. The Surviving Sepsis guidelines talk about the importance of antibiotic stewardship, to not inappropriately use antibiotics, but if someone has the signs and symptoms of severe sepsis, they're at high risk for mortality, and starting a broad-spectrum antibiotic on them has the potential to save a life, and outweighs inappropriate use of antibiotics, because this is not an inappropriate use of an antibiotic. And so if you read in the guidelines, they do talk about that. The importance in a sepsis program is to start those antibiotics broad spectrum and then de-escalate as you get your cultures back And that's where the antibiotic stewardship piece comes in. So the 3-hour bundle is measure lactate, obtain blood cultures prior to administration of those broad-spectrum antibiotics, administer broad-spectrum antibiotics, and then administer a 30 milliliter per kilogram fluid bolus for hypotension or lactate greater than or equal to 4. The 6-hour bundle, if I'm still hypotensive after the 30 milliliter per kilogram fluid bolus, then I need to apply a vasopressor. The primary vasopressor that's recommended is Levophed or epinephrine. And if I had that persistent hypotension or my initial lactate was greater than or equal to 4, I need to ensure that I've adequately resuscitated the patient to ensure that they have good tissue perfusion. Because remember, the pathophysiology that we're trying to overcome is that poor tissue perfusion that's leading to the organ dysfunction. So for the hospital, they have a whole host of, and that's on the next table, a whole host of interventions to do to assess whether or not we have adequate volume status and tissue perfusion. If my initial lactate was elevated, I need to repeat that because the science tells us that as I've adequately resuscitated and restored perfusion, the lactate should be lower. For resuscitation for lactate between 2 and 4, there's no specific evidence that I have one study that where they aggressively resuscitate with a lactate 2 to 4, but the guidelines are not specific to recommending the 30 milliliter per kilogram fluid bolus when the lactate is between 2 and 4. Typically, if it's above 2, it means that they have some hypoperfusion because increasing lactate and is a sign of tissue hypoperfusion because I move from aerobic to anaerobic metabolism and I produce lactate. But at this point in time, it's the clinical judgment of the provider on how much fluid to give that person that has severe sepsis with a lactate between 2.1 and 3.9. We'll talk a little bit more about this. I'm not going to focus on this because I think the majority of this audience is not hospital-based, but the clinicians in the hospital have to decide how they're going to reassess if there's adequate volume status and tissue perfusion. And they can either use a focused exam or other hemodynamic variables, CBP. They could use SpVO2, bedside ultrasound, or dynamic assessment of fluid responses. So these are the step 2 definitions. These are the definitions that CMS is using. We're coding by. But as I said before, in 2016, the Surviving Sepsis campaign, the European Society of Critical Care Medicine and the American Society of Critical Care Medicine got together and published new definitions for sepsis. And so in that, they removed the term severe sepsis and just someone that has organ dysfunction and an infection has sepsis, and define it as a life-threatening organ dysfunction caused by a dysregulated host response to the infection. So it does away with SIRS, severe sepsis, and sepsis syndrome. It's using the SOFA score to identify organ dysfunction, and then they identify septic shock as someone who is vasopressor dependent and has a lactate greater than 2. So in developing these definitions, they used lots of data sets and looked for, in the septic shock population, they looked for someone with a high mortality rate greater than 40%, and then looked at what the patient looked like. And they were vasopressor dependent and had a high lactate. And sepsis was someone that had a greater than 10% mortality. And that's what they looked like. So they had organ dysfunction and an infection. They also identified, since the SOFA score is really only done in the ICU, they identified a quick SOFA, a Q-SOFA, and that is a respiratory rate greater than or equal to 22, altered ventation, or a systolic blood pressure less than or equal to 100. If I had two out of three of these criteria plus an infection, then I should do a full SOFA score on this person. So that was what they were using, recommending for early recognition. So on the right-hand side in the bar here is the SOFA score. So it's looking at respiratory, renal, hepatic, cardiovascular, hematologic, and neurologic, and then gives you a point. And if you had a 2 or more change in your SOFA score, then that's new organ dysfunction. So the challenges we have with the new set 3 definitions is that SIRS is not a part of it. And the most appropriate use for SIRS is that its presence prompts an immediate search for both infection, its possible source, organ dysfunction, and are they together. It's also potentially going to result in late recognition if we're not using SIRS. Sepsis is a problem only when life-threatening organ dysfunction is already present, fails to recognize the spectrum of the illness. It minimizes the importance of the infection to its evolution and at its principal driver, and devalues that systemic host response. It doesn't also recognize cryptic shock. So we know if a patient has a high lactate greater than 4, but is not hypotensive, they still have a high risk of dying. And in the new definitions, this population is not picked out. Another fear is that we'll use QSOFA as a screening tool. QSOFA and SOFA are predictors of mortality. They're not a test of early sepsis and identifying someone who might be at risk to progress to organ failure. So they have the ability to predict mortality and prolong ICU stay, but they have not been used to identify if we can reduce mortality. So 500 years ago, Nico Machiavelli said, as the physicians say of hectic fever, that in the beginning of the malady, it is difficult to detect but easy to treat. But in the course of time, having neither detected nor treated in the beginning, it becomes easy to detect but difficult to treat. So we need to get sepsis and identify it when it's difficult to detect but easy to treat, as opposed to when it's obvious that this person has sepsis, but then it becomes difficult to treat it. So the hallmark study that the landmark study that is the basis for the Surviving Sepsis Campaign bundle is the early goal-directed therapies that was study published in 2001 that was done at Henry Ford Hospital in Detroit, Michigan. They looked at 263 severe sepsis patients and identified them in the ER, provided them with early goal-directed therapy, which was the 3-hour bundle, as well as resuscitating them to an SpVO2 greater than 70 and a CVP greater than 8 to 12 versus standard therapy. And for the first time, we saw a 16% reduction in mortality with a number needed to treat of 7 to 8. As soon as early goal-directed therapy study was published and put into the guidelines, the question of all scientists and practitioners were, which of the components of the early goal-directed therapy bundles are necessary and are the ones we need to ensure get done to impact outcomes. And so 3 studies, the Process, Promise, and Arise trials, were done between 2009 or 2010 and published in 2014 and 15. This is the meta-analysis of putting all of those 3 studies together and getting their results. And what they identified, they were comparing early goal-directed therapy with usual care. And the important things to remember is that prior to randomizing into those 2 groups, 92% of the patients were identified early and provided the 3-hour bundle. So at least 2 liters of fluid and antibiotics were given within 70 minutes of presenting to the ER. And so it was really that 6-hour bundle where the variation occurred, and they didn't see a difference in 90-day mortality. But this emphasizes, if we're trying to answer the question, which components of the bundle are key, we've answered it that, and they got an 18% mortality in the U.S. and Australia, but in both arms, the early go-directed therapy as well as the usual care. So this is telling us that that early recognition and that 3-hour bundle are two key interventions to reduce mortality. The state of New York, based on the death of a 12-year-old, Rory Stanton, put together in 2013, they required hospitals, the Rory Stanton law, to follow protocols for early identification and treatment of sepsis. They published their results. You can see them here. 82.5% of the patients had the 3-hour bundle completed within 3 hours. Awesome. And what they identified is that the longer time it took you to complete the 3-hour bundle, you were going to have a higher in-hospital mortality, as well as antibiotics alone. If you delayed administration of antibiotics, that was going to result in a longer mortality. So here we have another study that is, again, reaffirming that the early and that 3-hour bundle are key to reducing mortality. So the next few slides are related to research telling you the importance of giving a broad-spectrum antibiotic as well as the timing of that antibiotic. So here, this study back in 2009 by Kumar tells us that we have a 5-fold decrease in survival if the initial antibiotics we hang are not the right antibiotics. So it's important to hang that broad spectrum so that you cover the potential organisms that the patient might be infected with. This was an initial study, and there's some follow-up studies that in patients with severe sepsis, every hour of delay in hanging that antibiotic decreases their survival by 7.6% per hour. Other more recent studies that support antibiotics and early fluid resuscitation. This first study, the timing of early antibiotics and hospital mortality and sepsis, affirmed every hour that elapsed between presentation and antibiotic administration was associated with a 9% increase in mortality. And this second study here, increased time to the initial antibiotic was associated with progression to septic shock patients. So every hour until that initial antibiotic is administered was associated with an 8% increase in progressing septic shock. And when they progressed to septic shock, they had longer length of stay and a significantly higher mortality. So again, reaffirming that antibiotics are a key component of managing sepsis. Here's some studies related to the importance of early fluid resuscitation, that increased mortality occurred with later fluid resuscitation. If I waited greater than 180 minutes from that initial hypotension to fluid resuscitate, my mortality was almost 20% versus 13% if I started it in 30 minutes. And increased fluid administration in the first 3 hours is associated with reduced mortality. Another study, here's a study of, if you want to look on, and I saw a question in the chat about giving fluid to the patients that have a lactate between 2 and 4. This study, multi-centered study in Northern California Kaiser, put in a 3-hour treatment bundle for patients with intermediate lactate. And what they found was in giving those patients the fluid, and they got around 2 liters, that they saw a decrease in hospital mortality. And when they looked to see which populations had that decrease in mortality, it was the patients in heart failure and the patients in kidney failure that had received the 2 liters of fluid that had the significant decrease in mortality. Also, early fluid initiation was associated with lower hospital mortality and mechanical ventilation. So, again, study after study reaffirming the importance of early antibiotics and early fluid, along with early recognition. In the hospital, if you are concerned on giving fluids to these patients, this is an algorithm to help you in application of that fluid resuscitation for the adult septic shock patient, and it's in critical care medicine. So in the 6-hour bundle, and we'll spend just a couple minutes on this because I think most of the attendees are not necessarily in the hospital, is applying vasopressors for continued hypotension and then reassessing if my patient is adequately volume loaded and has adequate tissue perfusion, and then remeasuring the lactate. I can assess volume status and tissue perfusion with any of the following. So your team needs to decide how are you going to do that. Most teams do a combination where they'll do a physical assessment, but then they will also use CDP or dynamic assessment of fluid responsiveness. And so in that dynamic assessment of fluid responsiveness, you have to have an invasive, well, you can have a non-invasive device, but you have to have a device in that will give you the patient's stroke volume. And so we now know that fluid, we now know that, well, I lost my train of thought. So you need to have a device in that will allow you to record and measure stroke volume. And so you can get that from an arterial line with a special transducer. There are other devices that are totally non-invasive that you can get that information. And so as you're deciding whether or not this patient needs additional fluid after that 30 milliliters per kilogram fluid bolus, you look at their stroke volume and you're really trying to optimize their cardiac performance and where they sit on the Frank-Starling curve, and that's the top picture here. And so the x-axis is the end-diastolic volume, and the y-axis is how much stroke volume you have. And you can see it's a curve, and you want to see where your patient is on this curve to know if they're still on the steep portion, then they are volume responsive, and more volume can increase their stroke volume. And our goal here is to optimize that stroke volume so we optimize the blood flow to the tissues with the oxygen. So you can either give a 250 or 300 or 500 normal saline bolus over 15 minutes, record the stroke volume before and after. If you see a greater than 10% increase in stroke volume, then your patient is probably still on this steep portion of the curve, and they're said to be volume responsive. If you're not sure you want to give the actual fluid because maybe you've already given 5 liters and you're not sure if they really need additional, but you want to check, you can do a passive leg raise. There's a meta-analysis that the test is highly reliable in predicting fluid responsiveness. And you do it by starting the patient in a semi-recumbent position, you lower their head, and then you raise their leg. And again, you need a device that's going to measure stroke volume, and you look at the stroke volume before and after. Again, if it's greater than 10% difference, then 10% increase, then this patient is volume responsive. Now, this passive leg raise is a virtual fluid bolus, and so if you determine that this patient is volume responsive, when you lower the leg, the bolus is gone, so you actually need to give the bolus. It's recommended to have tools and checklists to ensure that you've done each of the components of the bundle. Here is an example of the checklist we used at our facility, and this becomes a handoff tool as the patient travels from the ER to the ICU or from the floor to the ICU, and it has the 3- and 6-hour bundle components. So how are we performing nationally on these sepsis bundles? And so this is information from a presentation back in November. And I'm going to walk through these pretty quickly so we have some time for questions. and you'll have these to refer to. 99% of the hospitals are submitting this data, so that's good. We are rated on all or non-compliance, so that means if the patients get each of the bundle elements that was appropriate for them. And as this measure has matured, you can see we've gone through each of these is a different version, and so we've clarified things, added things, and so the most recent version, and actually this isn't the most recent, there's a 5.3, but this data is only going up to Q1 in 2017. But large population, all or non-compliant is sitting at about 47%. I think best in class, currently people are in the top 10% of performance are hitting 70% for all or non-compliant. And so if you look at the different components of the 3-hour bundle, this is looking at lactate blood cultures and the broad-spectrum antibiotics. And the first quarter of 2017, compliance for that was 74%. And looking at each of the different components for that bundle, so 89% got antibiotics, 92% got blood cultures, 89% got lactate. So each of the different individual elements. And then the repeat lactate, 81% are getting the repeat lactate, and this is the 30 milliliter per kilogram fluid bolus on the appropriate patients. Those are the patients with severe sepsis that have a blood pressure systolic less than 90 or an MAT less than 65, and or they have a lactate greater than or equal to 4, and that's 69%. And which is actually pretty good. Vasopressors, 78% compliance. That reassessment of tissue perfusion and volume status is sitting at about 55%. And then if you look at the mortality, the patients that passed, meaning that they achieved all of the bundle elements in the time frame, their mortality was 22.6% versus the ones that didn't pass were 31.4%. And then here is the combined severe sepsis to septic shock mortality. And actually, this is Michigan's rate. So, anyways, in summary, sepsis affects over 1 million people a year. A person dies every 2 minutes. 80% of the sepsis starts outside the hospital. The key to saving lives is early detection and early aggressive intervention with antibiotics and fluid and having them in the right place. So we are open for questions.
Thanks, Pat. Operator, at this time, can you open the lines for Q&A? We'll take a couple questions here. And I also want to say that the slides will be emailed out to all the registered participants following the webinar.
Ladies and gentlemen, if you have a question at this time, please press the #1 key on your telephone keypad. If you have a question at this time, please press the #1 key on your telephone keypad. Our first question comes from David. Please go ahead.
Hi, David. David, you might be on mute. I can't hear you. Hello?
Our next question comes from Marla. Please go ahead.
Marla? Are you off mute? Did you have a question?
Our next question comes from Susan. Please go ahead.
Hello, I had this in the chat box as well, so I just want to make sure I get an answer to this. But the fluid, when you're talking about fluid overload, if a physician does document that it's potential fluid overload in the record, is that an acceptable exception, do you know, for the sepsis 1 measure?
It is not.
It is not. Okay, that's what we thought as well. And then have you heard anything about using the person's ideal weight to calculate fluids, like, for example, bariatric patients versus their actual?
So that was a change in the 5.3 version that you can use their ideal for someone, and I can't remember the BMI. It has to be a BMI greater than something, but yes.
Thank you.
Welcome.
Our next question comes from Mary. Please go ahead.
Hi, Mary.
Mary Shop, your line is now active.
I'm so sorry. My question is, I would really like to know what the difference between Step 1 and Step 2 is.
So Step 1 is the CMS evidence-based bundles that are part of the core measure for CMS. Step 2 are the current definitions that we use in the United States for identifying patients with sepsis, severe sepsis, and septic shock. And then Step 3 are the new definitions that came for sepsis that came out in 2016, but the U.S., meaning CMS and the billing coders, have not moved to those new definitions.
So does that mean Step 1 and Step 2 complement each other?
Yes, Step 2 is the definitions. It's the second version of sepsis definitions, and Step 1 are the first sepsis core measures.
Okay, great. Thank you so much.
You are welcome.
Ladies and gentlemen, if you have a question at this time, please press the number 1 key on your telephone keypad. We have a question from Jill Ice. Please go ahead.
Hi, Jill. What's your question?
Jill, your line is now active. Our next question comes from Sunny. Please go ahead.
Hi, I was curious, do packed red blood cells count, are they eligible to count toward the 30 cc's per kg fluid resuscitation?
So actually they're not in the core measures, but that doesn't mean clinically if that patient needs red blood cells, that clinically is what you should do. But you will not count for part of the 30 milliliter per kilogram.
Okay, thank you.
You're welcome.
Ladies and gentlemen, if you have a question at this time, please press the number 1 key on your telephone keypad. We are waiting for callers to join the queue.
So I can start going through the chat and answering some of the questions in the chat until we get another question in the queue. Is that okay?
Sure, Pat. It looks like we have 2 more minutes.
Okay. So do you get a low potassium with sepsis? And again, this is it's not necessarily something that happens in sepsis, but as your renal function changes, it can impact your potassium. It depends on where their sepsis is coming from. If they have extensible losses, if their sepsis is coming from a GI infection, they could be losing potassium that way. So not necessarily, but it is monitoring someone's electrolytes is important in sepsis. You say early antibiotic stewardship programs. So early antibiotics, but antibiotic stewardship says no. And I answered this through the presentation, but I would encourage you to read the Surviving Sepsis Campaign Guidelines from 2016, and they have a section on antibiotic stewardship and why early antibiotics in someone with severe sepsis trump the need to not give antibiotics for a stewardship program.
It looks like we're at the top of the hour now.
Okay.
Thank you again, Pat, for speaking with us today. This concludes this educational session. Please stay tuned for details on our next webinar titled Early Recognition and Management of Sepsis, a Post-Acute Settings Toolkit. Before you close out today, please complete the survey that will pop up. We appreciate your feedback on today's session. Once you have completed that evaluation, you will receive a certificate of completion. Please make sure that everyone on your team has participated in this webinar receives a copy of the certificate by following the instructions given in a follow-up email. The session was recorded and will be available on the Lake Superior Clin and Great Plains Clin websites in about 2 weeks. Thank you all for participating and have a great afternoon.
Ladies and gentlemen, this concludes your conference. You may disconnect at this time.